to our webinar series, Talk 2. Today, just before we get started, I'd just like to tell all the attendees that on the right-hand corner of your screen, you have chat, questions, polls, people section. You can chat among yourselves in the chat section, and on the question section, it's better to type in your questions. And if anyone wants to come on board to ask question to the guest speaker today, that is after the talk, he's welcome to do so. Just tell me and I'll bring you on stage. That is basically connect your video link so that you can ask your question audibly and visually. So today we have Dr. Rajan. He's a consultant plastic surgeon from Apollo Chennai. My association with Rajan goes back to a very long time, and he's a very endearing friend of mine. We have done a lot of work together, medically and otherwise as well. That is for another day to talk. But today we have him here amongst us, and he's going to speak to us about plastic surgery. Rajan, you're here with us?
Yeah, I'm done. I'm here.
Just before you get started with today's talk, give us a little introduction about yourself and what you do and what kind of practice do you have, before we get started with the talk.
Okay. So let's make it very brief. I did my MS in '99 and joined Army and I was in Army for 5 years. When I came back, I joined Apollo to do my further training in plastic surgery. And ever since I've been here since 2005. We are a team of 4 people. We cover a wide range of surgery and hospitals in Chennai. But our specialty and focus is on cancer reconstruction, in specific head and neck reconstruction, in addition to trauma and cosmetic surgery. So with that, a small brief introduction, if you would say okay, then I will start my talk.
Yes, sure, Rajan, go ahead. Maybe you should maximize your screen share. Put it in presentation mode before you get started with the actual presentation.
Fine.
Yes. Yeah, I'll just make it center stage. Yes, you can go ahead now. Yes.
Thank you.
Hope everyone can hear and see the presentation. Yes, they can see and they can hear.
Okay.
Go ahead.
Good morning. So this is my team. We practice in Apollo Chennai, Apollo Cancer Hospital, or otherwise known as Apollo Specialty Hospitals, and we're a team of 4 people. So the origin of the word plastic is Greek in origin, to mean originating from plastin, but it has gone through various stages from Greek, Latin to French to the present plastic, which actually means to mold. And because it is common to our surgery as well as to the commonly used plastic material, so both of them are getting molded, and what we do is but mold the soft tissue and bones and other hardware so that we can give back the form and function of an affected part. So what is plastic surgery? It is not only about the use of plastics, but also and mainly a branch of surgery to restore the form and function. So mostly we know that a layman's idea of plastic surgery is but cosmetic surgery, but that's only about 10 to 20%. In practice, plastic surgery is involved wherever there is a wound, any part of the body, and whether acute or chronic, there is no skin, then we are called into your opinion and our expertise and our surgery. Plastic surgery is now, like, people know that this is the origins in India, because at the time people used to lose their nose as a form of punishment, and the ancient father of plastic surgery is Sushruta. What did they do? They used to reconstruct noses. At the time, it's almost in 600 BC. So, and now after 2000 years, we still are using the same validated technique to reconstruct and nose. So why I'm starting this is plastic surgery is about the skill, patience, and knowledge of your body and the tissue handling techniques. If you see in this person, the forehead skin is used to reconstruct the nose, both inside and outside the nose, but in stages, so that we get an almost normal skin. But you will see that it's a good nose, but not the best nose. That means there is an indefinite opportunity to do better and better on an existing work. That means we can do as long as either the doctor or the patient needs further refinements. So it all started in the year during the World War One and Two. Until then, surgery was very crude, but because of trench warfare and people getting dug in and getting blown their faces off because of machine gun injury, and later because of the Industrial Revolution, there was a lot of mutilating injuries happening for the whole of the from head to foot. However, the plastic surgery grew very much during the Second World War to basically take care of facial injuries and reconstructing them. So, the war injuries led to an advancement in reconstructive surgery during peacetime because of the time spent in the technology and better delineation of anatomy and studies on anatomy. The functional aspect of restorative surgery was enhanced, and when there was economic prosperity, there was a demand for cosmetic surgery. That is how we get into reconstructive surgery, functional surgery, and cosmetic surgery. And all of them compose the word plastic surgery. So, because of the words, the understanding of physiology, and to stress importantly, because we take long time, we need very good anesthesia. So, because the advances of anesthesia, even more and more finer and long-standing plastic surgery can be done, of course, supported by antibiotic and good surgical techniques. To say, but it is the understanding of the anatomy and tissue handling that puts plastic surgery on a pedestal level. There are a lot of subspecialty and super specialties. Basically, one surgeon is going to do one surgery in the future. So what is the objective? Restore form and function, right from head to foot. What makes it special is that we got a very technical tools available, right from closing the wound primarily, or when the skin loss is there, then you can use skin grafts, flaps, implants, and so many things. So the issues that require plastic surgery are congenital deformities, traumatic wounds, post-cancer defects because of malignancy, degenerative disease like rheumatoid, and of course the aesthetic and other miscellaneous things. The subspecialties can be broadly classified into craniofacial and lip and palate, burn surgery, hand and foot surgery, head and neck reconstruction, and aesthetic surgery. There are many more miscellaneous small subspecialties like lymphedema and hypostosis or sex reassignment surgery. However, I'll give you a few examples for each of them. So this is a congenital defect, cleft lip, but if you see, we not only recreate the form of a normal lip, but also we have to correct the palate so that the baby can drink and feed as normal as possible, and the speech also will be as normal as possible without regurgitating. However, the most common reason that we are called upon is basically for trauma. Very common. The trauma is unpredictable and requires each and every case requires a careful assessment. So, if you take into account hand injuries and limb injuries and facial injuries are more common compared to burns, but burns can be really demanding in many people. So, this is I'm just putting photos which is like more common and which we see in day to day. And this is a very common thing in pediatric age group, spillage of hot water or milk or anything, and they can just get away with conservative management like a artificial collagen skin. However, most of the people who get burns more than 30% deep burns or 60% superficial burns will end up in ICU setup requiring multiple surgeries. This is one of the commonest cause of referral for us because of not following safety protocols in more and more so in lesser developed countries where the safety norms are not followed, and in one moment of lethargy, they lose limbs like this. So this is basically a hand that got trapped into a machine that is like it pulls in and strips off it's called a degloving cum crushing injury. But this is more common because people don't wear helmets. However, the results can be generally given better than compared to hand injuries. Only problem, most of them are worried in our Indian scenario is the hyperpigmentation that is very common after facial wounds. This is also very common. The the facial injury of the nose, lips, chin, and the ear are very common in the pediatric age group. However, I'm interested in talking about malignancy because this is a bread and butter. So wherever there is cancer and there's loss of tissue, we are called to play. Here you could see how in the earlier photos that I'm talking about, this is like about 2 decade old photo, they used to transfer of the skin from one end of the body to another end and then cut the other lower end and transfer it like that. It used to be very tedious, but because of understanding of anatomy, we got better and quality flaps available. And this is called the typical ladder because for every patient we can give a skin graft or a microvascular flap. So we use from the so-called ladder approach, direct closure, then skin graft, local flap, and free flap. That means we should use the most efficient surgery that gives the most aesthetic result without compromising on the morbidity and mortality of a patient. So wherever there is tissue loss, plastic surgeons have a role to play. But there are certain times we know that a high-end surgery will give a better result, even though it might be taking a long time, it may be more costly. So I'll start with the most basic thing. It's a bed sore, treated well, conservatively, but it's going to take ages to heal. So all that we need to do is once the wound is ready, we put a split skin grafting and this will heal in about 2 weeks time. However, if you see, there are many people who have small and small to medium skin cancers. So in face especially, there must be matching of the defect skin which we construct to the surrounding skin. So what better skin can be than the adjacent skin to the defect? So this is called a local flap because the flap that we transfer in this case to cover the defect or sharing a border. That means the defect and the flap share a border. Therefore, the result also will be good. Here we use the Limburg flap to take care of a defect for a BCC tumor. I'll make it faster. This is a bigger one, large tumor. Therefore, local flaps cannot be done. So we have to take it from the thigh. It's called a ALT pedicle flap. We put a mesh and then we put the skin and then we cover it. But what we specialize is microvascular surgery. This is an ideal patient with an ideal result. You can see that the tummy area is being closed primarily. That skin can be split into two, and we do a microvascular anastomosis for the artery and the vein. She has undergone a subcutaneous mastectomy, including loss of nipple areolar complex. So we put the skin and tissue, fill the volume, give the required amount of skin, give the shape. Then what you see is nipple is nothing but tattooed done on a reconstructed nipple. This is the best result that one can anticipate. However, there are further advances. Each square that you see in the photo is 1 millimeter by 1 millimeter. If you want to do vessels less than 1 millimeter, it's called submillimeter, and we need very high-end instruments and good technique. But the magnification goes from 10x to 25x. This is especially useful. In this case, you can see the tip of the finger is gone, and it is not a simple cut, but it's a very rough cut. So obviously the arteries will be so small. If you use high magnification, you can attempt and save not only the tip, but you can make it viable and get the function back. And this is a very good result. Now, let me go fast through this. Based on the blood supply, it can be random, that like a local flap. It can be axial, like I said, the flap, like a groin flap I showed. It can have the skin and muscle, myocutaneous. Fascia and the skin only, it's called fasciocutaneous. It can have the skin and the bone called osteocutaneous, and a combination of these. Also, whether the blood supply for each skin is, whether it is still attached to the body, called pedicle, is it attached but only with the blood vessel, is called islanded, or you are transferring from one area to another. But this is the most important slide. It's not the technique which I have, but what we do for the patient based on the position of the scar, the pliability of the tissue that I give, is it hair bearing or not, the color match is good or not, whether volume is required, bone is required, and sensation is required. But the landmark that happened was in 1940, 1960, and these are people who contributed to local and regional flaps. It stood the test of time. So one example I'll give is the mouth, loss of lip because of cancer, and all that we do is a Karapangee flap mobilization on either side, the aesthetics will be very good because of almost natural wrinkle lines that correspond to the scars. Regional flaps. This is our workhorse even now in our place. Those who go second surgery or cannot get this microvascular surgery because of morbidity issues, then we use this. One example is this deltopectoral, and what we commonly use now is the myocutaneous pec major flap. We almost do it every week for some patient. The skin and the cheek skin and the lining or the buccal lining is gone, bone is gone, but we don't put the bone, only skin, muscle, and mucosa. So how it is it? We raise it from the chest wall. Skin is attached to the pec major vessel and the muscle. The muscle is taken and got underneath the neck and sticks to the cheek for the replacing cheek skin and the buccal mucosa. It is one of the most dependable flaps in plastic surgery. But the revolution was in the early end of the 20th century, where the ability to take skin tissue, it will along with its artery and connect it to some other part. It has been there for long, but it's in the last 2 decades that refinements have happened. You can take it from anywhere and put it to any place where skin is required. I'll just give 1 or 2 examples. So this is called the anterolateral thigh flap, where we use the thigh, skin, fat, and muscle based on the lateral circumflex femoral artery, and you can use the based on the posterior collateral radial artery to take skin from the lateral arm. You can take the fibula along with the skin and muscle. You can use the radial forearm, which is one of the commonest and easiest to start with in your career, and you can use the abdomen, skin, and muscle for breast reconstruction. I'll just give 1 example each and go away. This is how we raise the forearm flap from the base of the radial artery, and here is the case. You need a thin skin. You need to reconstruct the outer skin, inner lining, so it is marked, measured, and it is superimposed on the forearm so that it comes along with that. So, and this is a good result for him. It will not only make him more pleasing, but also we can do further refinement and make it even thinner. And now, same thing, but we are replacing bone for bone using the fibula raised from the leg. And see this LMD. Now she's got a lining that is a mucosa, skin, and the reconstructed mandible with the fibula bone. However, where we score is the expertise using jejunum and gastro-omentum to reconstruct pharyngoesophageal defects. So what happens is basically this patient, you can see the trachea is gone along with the laryngeal box and the esophagus. So we basically have a gap. So we use the jejunum, harvest it, and put it. All of this harvesting to anastomosis for the artery should be over within half an hour. And you have an enterostomy. You can see post-op how the patient can eat and drink using that. Similarly, we can use the omentum and the stomach. You can see that the omentum and the stomach is harvested, put it in, and you construct the tongue for that. And now you see the reconstructed tongue. It looks so normal, and see the smile on the base. And you can also see secretion of the stomach coming out like saliva. However, it's all gory, but I would like to end on a very pleasant note, which we do in aesthetic surgery. It is nothing but art mixed with surgery, and a surgeon as an artist or an artist as a surgeon. So even though people say why they want cosmetic surgery, do they want to become celebrities? No, it is to increase their self-confidence by conforming to what is considered normal in their environment. What is beauty in one place need not be beautiful in another place. That is how people seek cosmetic surgery. It varies from face, neck, breast, arms, tummy, and buttock and hips. Most of it for reversing the effects of aging and sagging because of fat atrophy. So face, most commonly it's nose, eyelids, forehead, and cheek. I'll just go with 1 or 2 examples. This is one of the most sought after procedures for rhinoplasty, especially in the Asian community because of the being too wide, too big a nose, crooked, or bulbous. However, more common is hump jaw. It's one of the simplest thing to correct, and where you can see it's called the Roman hump for the nose. It requires a very simple surgery with or without other components of rhinoplasty. But this is very common in Asian population, especially Indian population. There's a depressed note. All that you have to do is augment with a piece of rib cartilage, and the nose can be lifted up. And in the Asian places, because of the pregnancy, there's laxity of skin and poor tone and lack of exercises. So what we end up is nothing but a flabby abdomen. So what we do is remove the excess skin folds, fat, repair any hernia, contour the waist with tightening or liposuction, and relocate the belly button. See how a postpartum lady, how on both views, you can take out the excess fat, take out the excess skin, and give an almost normal, what do you call, fit abdomen, tight abdominal wall. But what we see more commonly, may be comparable with abdominoplasty or tummy tuck, is breast surgery. And they vary from augmentation, reduction, asymmetry, reconstruction, and gynecomastia. If there's one surgery that is so happy, the patient and doctor is happy, is breast surgery, because in augmentation, even though it is very popular in Western world, it is very not so in our place. But most of the people who ask for augmentation are transgenders. You can see almost flat, and how much happy they go back home. In one day, they come without their flat chest and go back with a full breast. But breast reduction is common in the Asian population because most have too large, too heavy, or painful breast with stiffness of neck and back and severe embarrassment. So this is what a normal person with a big breast would be having, and they'll also have intertrigo because of sweating. And this is the end result of a surgery after reduction of the bed. You can see the sagging has come down, the volume has come down, and it's looking more pleasing. One more patient, you can see pre-op and post-op, and how it fits into a bra. If you wear a bra and see, it's the shape that matters, not the scar actually in breast reduction surgery. And our expertise is called into because not only for reconstruction but also for reconstructing the lost breast in breast cancer. This is one of the places there's a huge scope in the years to come. The more the people are going to work and become independent, and independent women are going to ask for this. However, you should always give them non-surgical options like silicone prosthesis. If not, we give this. So what we do, basically take the skin from abdomen or any other part like thigh, reconstruct. This is a see the previous one. The second one is a better reconstruction, and when they wear a bra, is very unlikely. So what you lose in the breast, you gain with a tummy tuck. And the most satisfying surgery in aesthetic is gynecomastia. All people who admire breast but they don't want it is a male with a female breast, and it is very embarrassing. But a daycare surgery that will help one and all. There are lots more like what do you call scar surgery, keloidal surgery, and hair transplantation. But that is for a different day. This is my team: Dr. Anthony, Dr. Shivram, Dr. Hari, and myself. Thank you.
Thank you, Dr. Rajan. That was a quick overview of the kind of work that you do.
I hope I kept to the time.
Yes, you did. Yes, you did. Thank you so much. Thank you so much for sticking to the time. I was actually wondering, it was very long, but you stuck to the time. I personally know Dr. Rajan from a long time. I've personally seen his work and his group's work, and they do amazing work. Most of these patients in the cancer hospital have extensive resections, and they end up with a lot of defects, and it's amazing. The end result of this work is really amazing. So any questions, please come forward and write in your questions. Just to get things started, Rajan, this plastic surgery, most people think of it as aesthetics and cosmetic. So what is exactly the difference? I mean, there is some sort of annotation to being aesthetic and to being cosmetic surgery.
Aesthetic is the medical jargon for common use amongst the medical community, and cosmetic is for a layman. I don't see a difference. But it is an approach that we are seeing of late, that the cosmetic surgery or aesthetic surgery clinics don't call them as patients. They call them as clients. And for me, it is a bit of a problem because my lifelong goal has been to doctor to treat patients. I never knew that I would one day be calling them as clients. So the words don't matter. It's how is your approach. And maybe it's true because people who need cosmetic correction, they don't want to be labeled as patients. Maybe it's working for both the doctor and the patient to be addressed as clients. And the atmosphere in a cosmetic setup and a non-cosmetic setup is entirely different. People are normal. And you know that when there is lot of economic, disposable income, there is also growth in cosmetic surgery. That means people who come to spend money seek better quality. They don't take a lesser quality. But that is not so in hospital. They are full of sick people. They don't want to mingle with sick people. They're looking for something better than what they're having. So maybe it's justified for those who do that as a clinic, but I'm still, for us, it's only 20% cosmetic. So we basically do it in different setups: cancer surgery in cancer hospital, cosmetic surgery in cosmetic clinics.
Right. Okay. Thank you. So we have questions here. Our urologist, Dr. Arun, is our urologist, and he has a question.
Yeah.
Sex change surgery. Do you do this? And how is the Indian law with respect to this surgery?
So in our private practice, we get about 1 or 2, because Apollo is a private hospital and that's where our practice is. So we get about 1 or 2 per year. 90% of them are male to female, and they exactly know what they want. It means they don't come without knowledge. They have taken the decision to undergo over a period of time in many years, and the community bonding is there between them. It is usually one patient who refers the other patient. So if you see in terms of legal, we don't get much into it. We just put a few requirements. We say that you have to see our psychiatrist, and they have to see the endocrinologist, and they should also get an affidavit with the lawyer. And we just put on to one patient. They do most of it. Why? The reason is we like to just stick to what we offer and what we cannot offer. We otherwise it will become like trying to promote this surgery, and we want to be sure that they are medically and mentally fit for what we can offer, because it's a permanent procedure. It's a mutilating surgery, and there's no way you can go back. When the results are bad, you are stuck with the patient for many years. But to say the other note, you even give 70% of what they seek, they're still very happy, because more than the appearance, they want to feel accepted as the opposite gender which they want to change. Is that satisfy your answer? Yeah.
Yes, I think that's quite satisfying. Dr. Manjeet Pawar, he's our anesthetist from our hospital. He's one of the anesthetists.
Yeah.
And he says, thank you for that beautiful talk. And he's very happy that you appreciated anesthesia in your talk. Yeah. He says, how do you convince for the results in crush injury, amputated finger? Isn't it difficult to explain the results to the patient?
But what I'm trying to say, it's not about telling what you cannot do. It's about telling what you can attempt. It's very easy to convince a patient saying it cannot be replanted and you have to just go for a shortening and closure. But it is the effort that you put and making it survive on the tip that is more important. So if it's up to me to convince, telling no, you can't put it, and no, it's of no use, you lose money and all. But it's about that satisfaction of making almost an unviable tip, making it live, and that's what is more important. So and this can be done even just sedation and local anesthesia. It is, in terms of morbidity, it's so less. But I think it is attempt. Every attempt is the stepstone to the success for even a complicated case. So we basically get machine injuries or pediatric. I'm sure no father or mother wants a growing baby with an amputated tip. The tip loss might be only half of the nail plate or just half of the TPX or tip, but mentally it is still an amputation. So I can vouch for that with my own experience. Though we should not take amputation very lightly. It is a mental disability more than a physical disability. We should make all the efforts to put it back. She wanted to just throw it off because it is muddy. So that's what I'm trying to say. It was full of mud, and we had to clean it and do it. It is totally, it's actually playing God. You are deciding whether it stick or not. And what you can do is only attempt. What the result is only time will tell. And all the best results around the world is based on this one philosophy. You the attempt is yours. The time will tell the result.
Absolutely, I agree. You showed that wonderful picture of that breast reconstruction from the abdomen. When you showed the picture, I was actually wondering what actually have you done in this. I can't see anything at all. So it was amazing.
I put it.
Especially
so
the
if you
nipple
see, I don't know if you
reconstruction
noticed or not. That is the only picture which is not mine. I just wanted to show the ideal one and what we could do it later. If I just showed only what I could achieve, then it will not be very impressive. But if you see, it is in Westerner and somebody has done. I always show this to my patient because that is what you can. I'll say I can achieve maximum, and then what we can do is, because this is a commitment by the doctor and the team to give best results. Nobody is going to penalize you for making a little bit puckering and all. No, it is how it's like a potter or a sculptor who is putting all his heart and soul into it. It might be nothing for the patient. It's just a small scar. But if you're not happy, what's the point whether the patient is happy or not? So most of the it's thing are time consuming, and the results are improved after each and every patient. It means the more you do, the better you do. I think it's true for most of the surgical field, isn't it?
Certainly, certainly. So we have more questions. We have Dr. Shalaka, who is our obs gynae specialist, and she says, in cases of breast implants done for breast augmentation, does it impact the results of screening tests like mammogram or MRI breasts?
Yeah, initially this was apprehension was like when I used to do my early career, it was there. But with the MRI coming into picture, it is all changed. So whenever there's a doubt, you're going to do a tissue biopsy. So this has been solved, not based on our data, but based on Western data, because breast augmentation is very, very common compared to our country. So we use their data. But what is also worrisome, of late, the cumulative data suggests that the long-term association of implant and carcinoma, especially anaplastic carcinoma, there's a small chance. Now, how small, it may be insignificant, but if you tell this to the patient, the question is, will they accept or not? So what is the future might not be actually implant, but fat augmentation. So fat augmentation is the thing that is going to be there, or autologous tissue transfer like what I showed you. So when we do our what you call our tissue, you can always in future map it based on dye with that particular artery. You can do it. So I don't think it's a problem in trying to find out whether they'll have malignancy or not. The question is it so good that you can actually take the chance of cancer even though it is less than 0.1% and advocate implant, or you offer them an autologous. So if you see the industry, how it works, most of them who come from the entertainment industry to show their appearance, they usually have the implant till their career is over, and actually they come back later to say that I'm going to start a family, I'm done with my need, so please improve the implant and do something else. So I think that will be the future.
Right, okay. Dr. Abu Bakr, he's a general practitioner, but very enthusiastic person, attends almost all webinars, I mean all the CMEs that we have here in KIMS. He has a question for you. He says it's a great talk, but he's asking, what is the most common complication in cosmetic surgery and how do you handle it? Along with that, maybe we should add this as well. Dr. Manjeet, who asked the previous question about the amputation finger, he says, what about failure and litigation? Do you see these things as well? So maybe you can combine both of these and say.
So this is, if you see the US insurance rates for indemnity, the highest is for obstetric gynecology and plastic surgery anesthesia. So if you get fearful of litigation, you can never practice. So let's keep the litigation part separately. It is the communication part that is very important. If you don't spend time before surgery communicating and understanding your patient, you might pay dearly later. But if you spend enough time in the consultation, so my first consultation is usually about 45 to 1 hour for a cosmetic patient, but about 10 to 15 minutes for a onco patient, because their needs are different, the expectations are different. So it doesn't matter, you get see, if you see what is harassing or painful for the doctor, it is not whether you will lose the litigation or not. It is the fact that somebody put a litigation and that is weighing on you every day and till the period is over. So it'll be, I don't think we should get into it. Have a good indemnity insurance for a reasonably lot of money, and take every patient individually, thinking that they're good or bad in terms of as a candidate for surgery, not only based on what they're seeking, what you can offer, and also what is their mental status in their first what do you call consultation. If you think they're not going to be suitable for you, let go of the patient. Doesn't matter where they go. I think that will be the better approach. That's what we have been following. And touch wood, nobody's litigation put any litigation on me till now.
Excellent. That communication is the key, and understanding what
Yeah.
exactly the patient wants. Sometimes he may not be able to express, but by communicating to him, understanding what he really needs, and fulfilling that need, I think takes care of all
Yeah.
that.
Even for the finger, we tell them in percentage. We tell a crush injury got 50%, a blade knife injury got say 10% loss and all. But I tell them very clearly, the percentage is for me to explain my success rate and not the patient's success rate. For the patient, it is like none or all. Either they lose the tip or they don't lose the tip. So I always say, take your finances into account and their expectation into account, and not go by my success rate, but what will they do if they lose the finger. If they say they have only limited scope in terms of affordability, I tell them to go for the safer options.
Okay, excellent. So since you brought the financial bit into it,
Yeah.
Dr. Srinivas Bapu, he's our ENT surgeon, and Dr. Srinivas Bapu, I must say, is from Madurai, if I'm
Oh,
not
very good.
wrong. He was in Apollo Madurai earlier, so he's very familiar with the Chennai people. Anyway, so his question is: most of the plastic surgeries take a long time. Duration
Yes.
of surgery is long, and the
Yes.
cost is unpredictable. How do
Yes.
you do financial counseling, especially when you are in the private setup?
So it is by experience, basically. The two things I would make it easy for anybody. You should know what is the value you are giving to the patient. Therefore, you should know what is the income that you're going to derive from the patient, and then you should know what a particular hospitalization, that means the cost of hospitalization minus the professional charge. If these two you don't know, it is very difficult to give a what do you call estimate to the patient. There might be times when we have to forego money, that's okay, but in general, two components: the value that you give and what you need in return in terms of the professional fee, and what is the total cost of the stay. So if you're doing the first time, it may be difficult, you take a cut, but if you do it for longer and longer period, you know what is their average, and then you ask them to have little more than average, especially for cancer. Let us say it costs an X amount of money. Yeah, we tell them at least have and 1.5 times the money and then come. Because if the problem is not when there is this, some small problem, if it is unrelated to the surgery, it means they may have a very successful flap reconstruction, but may they end up in the ICU because of an MI or a DVT, and that is where they lose money. So if you don't cater for emergencies in ICU, then the patient going to get very angry with you. So my thumb rule is know what you can offer, know what you can charge, know the average charge of cost for each particular surgery, and then ask the patient to always have little more than what you quote. That way, I think most of them would be happy. And of course, waiving off a little bit of charge has never been a problem. We patients generally are happy with this.
Yeah, being upfront with the patient in the initial counseling itself, I think, is a good idea to keep expectations in order.
Yeah.
So, Dr. Arun, the urologist, has another question. After mastectomy for tumor, how many years do you wait before going for any kind of cosmetic surgery? Do you do it immediately, or is there a
No,
time
yeah.
gap?
So there
That's
are
what I think.
lots of groups advocating. It depends on your personality and your community of doctors. If you're doing only mastectomy every day for a livelihood, I think you might actually goad the patient into telling take primary reconstruction. That means you remove it and then you do it immediately. But there's one thing you should know: what changes the shape of the breast unpredictably is radiation. If the patient has to take radiation in addition to the surgery, for not only for the breast tissue but for the axilla, the two things they're going to have: one, there might be some change in shape of the breast, reconstructed breast, and also they'll have lymphedema of the affected limb. Plus, there's something that we should know: there is the opposite breast, and it might be very huge. So you have a huge opposite breast, then you have a question of solving it, and you will not have enough tissue to give it all to compare with the opposite. So we should also know that the patient is willing to go in reduction of the opposite side. So a lot of variations. So what I do is make it simple. Is the patient going to bleed money because I did the surgery, then it fails either partially or completely, and if it is not failing, patient had radiation after surgery, and it has made my surgery, initially it was good but made it worse because of contracture. I put myself in the patient's shoe or the husband's position, and then I try to go along with it. So I'm not the person who would push them into primary reconstruction, but if their nature of work, their personality demands that, and issue of cost is not there, I think we can go with primary reconstruction.
Right. So, which means many patients have it done immediately
Yes,
along with
yes.
the surgery
Yeah,
immediately,
yeah.
and a few can have it done later as well
Yeah.
if they so
They should
desire.
know,
Probably,
patient should know what is the morbidity and who pays for it.
yeah. Especially for example, radiation patients and all, it may make sense to do it later than immediately.
Exactly.
Yes, yeah. So we have a dentist, Dr. Smita Tarakan. She is asking regarding cleft lip and palate. When do you start with the initial surgery in an infant? What's probably the
I'm
time
not an
frame?
expert in cleft lip surgery, but I could say with confidence that the age has been gradually advanced earlier and earlier. Earlier, it used to be a rule of 10, 10 grams hemoglobin, 10 months of age, and 10 kilos of weight. That is the time. That's true in our country because of the lower weight of the patient. So they may not be eating well, they're malnourished. So if you keep the rule of 10, it is 10, 10, 10. 10 grams hemoglobin, 10 months of age, and kilos of 10 kgs at least. That's the right time to do. But more, and earlier it used to be in stages. You saw the previous picture, it's a whole picture. You do lip first, then cleft. The latest concept is whole in one. That means you do you do the whole of the lip, most of the nose, and most of the palate in one surgery. So cleft nose, lip, and palate can be done in one, and it is done better the earlier than later. When you say later, there's no point. The idea is you do it as early as possible that anesthesia can allow, and not go beyond the time when the patient starts talking. The more later you do, it affects their linguistics. Right?
Excellent. Okay, so we have another question. For some reason, my thing is loading. But
Mhm.
anyway, I just had a glance at the question. Dr. Tilal, he's one of our general physicians, but many of these general physicians are actually looking at furthering their studies and going into specialties. He's asking, what is the future scope of plastic surgery? I think you
I
can
think
give
I
a
just
big
said it in the
talk on this itself.
I
But
will
anyway,
I'll put it in my perspective.
yeah.
When I was training, there were 16 plastic surgeons coming out of Tamil Nadu. Tamil Nadu, not India, Tamil Nadu. Now there is about 30 to 40 people coming per year. Our Chennai group alone has got about 250 to 300 registered members. And we send one of the huge contingents to our national. That means we are looking at a huge amount of people. But plastic surgery has always been a question of affordability. We are like a pyramid. When they come, to the plastic surgery requirement, they have lost most of the money in the primary surgery. Or people are old enough that people don't want to spend their earnings on a old patient. But having said that, India is going to become a rich nation. It's going to become bigger and bigger. So, what is the scope? If you ask me in one question, it might be in future one surgeon, one region, or one surgeon, one surgery. The idea is you have to differentiate amongst the crowd, and you have to offer something better that others are not able to offer. If you take me, I am now specializing in lymphedema surgery because I know there's a huge population to address and they don't know where to go. So I've taken upon myself, in addition to head and neck reconstruction. So what do I do basically? I do head and neck reconstruction almost every week. I do finger injury almost every week. I focus on carpal tunnel syndrome, which is nothing but a very simple surgery. So what I do is choose complex surgeries, which I like to do, and choose also small surgeries, which I can deliver immediately as a result. You need to have a combination, but you must be identified with one surgery or one region where people can think, oh, Dr. Rajan does this better. I think that will be the future, and I'm sure this is true for even orthopedic or any other surgery.
True. Thank you. Everybody is very appreciative of your talk.
Oh, thank you. That's
any other questions?
I see one Partha Das in chat. What's the role of
Chat,
obesity and infertility? What's your take on obesity, infertility, and the role of liposuction? I'll make it simple in
Go
that.
ahead. Go ahead.
Obesity and infertility goes together. For one reason is they are on a lot of hormones. They are supposed to take a lot of rest. They don't want any exercise to cause a miscarriage. So people generally put a lot of weight. And we see, because the place where I work in my nearby is a infertility center, a lot of obese people. And I don't think all of them require bariatric surgery because they're very young in nature. They can actually lose weight and improve the tone very much as long as they put the effort in it. Because they eat well and put on weight, they might get easily misled into not to exercise later. But I think the trend is that people are very conscious with good diet control, exercise, and walking and running. I'm sure working women of the future will not be burdened with obesity because of infertility. But there is a role for bariatric surgery if the BMI is more than 30 with comorbid factors, things like diabetes, hypertension, etc., or an absolute BMI without of more than 35 without comorbid. These people maybe should be considered for bariatric surgery. However, they should also check up if they have the family history where people have been more than 30 or 35 BMI. Maybe their grandparents have been living for more than 70 or 80 years. Then I don't think they need to think about all this service.
Yeah, so there's that's great. I think that will satisfy Dr. Partha. Dr. Partha is one of our upcoming speakers, actually.
Oh, very good.
But anyway, so yes, so even you can join in if you like for the continuing of the webinar series. But in addition to that question about BMI, Dr. Sibasis, who is our bariatric surgeon, so he has a question for you. Yeah. He says, if a person with BMI 45, what is your stand? Is it bariatric surgery or liposuction? He's sort of putting it as
leave alone
this
45,
or that.
Leave alone 45. I don't advocate liposuction as a weight loss surgery. It is a contouring surgery. So if I have sent away many patients who are obese who seek liposuction. Liposuction what? Normally a safe technique they would say in European is about 500 ml to 2 liters under tumescent local anesthesia. Because they're all fit people who want to take a flap here and there little bit and look better. The patient in Asia is the other way. They are obese, they're not exercising, they're trying to think if liposuction can be a tool for weight loss. And I know my colleagues, my fellow colleagues do it like a motivational surgery. They take off 3 liters of fat and say, now you look confident and you can do exercise. Maybe it's true, but I don't advocate for any of my relatives to seek like that. I say weight loss is weight loss by effort. If not by effort, by motivation to lose diet control. If still not working, if it is jeopardizing your general health in terms of like you become a diabetic or you think it's better, then I say go for bariatric. However, I know instances, people who have been more than 35, 40, young people who after bariatric surgery they are off their diabetic medicines. I mean, they have become almost normal. So if you think in terms of as a metabolic surgery, it is good. Only my caution would be, I think you should take the history of their family into account and then see whether they are really a risk for, reduction of life expectancy. I think it should not be promoted as cosmetic surgery. It's got a role. I'm sure it's got a real definite role, but I'm not an expert on that to talk. What I feel and what I see is young people less than 30 after bariatric surgery require almost no plastic surgery. That means the skin is shrinking on its own after the bariatric surgery. It means it's readapting. But if you're going to come at 45 and do bariatric surgery, that tone loss and skin flap will require help from plastic surgeons. And see, one more question is, what can you offer for lymphedema? That is a topic in itself. It's a big topic. It's one of the latest trending topics in the international community because the range of surgeries has increased from nothing to bandaging and manual massage. That is the conservative part, leading on to surgeries like lymphovenous anastomosis, vascularized lymph node transfer, liposuction for the unredeemable patients, and skin loss surgery by liposuction and reduction of the flap. I got photos to show. Maybe one more time I can do because that is my special interest. And we are, I think I would proudly say I did the first lymphovenous anastomosis in our country because this is very, it happened in 2010 and 12 and we did it in 2017. But I am very selective about who should it be done. Lot of research papers are there in Japan because they do it for lifestyle. We do it for mobility problem. Here, it is becoming so heavy that they can't lift their hand or they cannot walk around. So the indications in India is different from Japan. It is different in Western countries. So you have to suit it to our custom population and then offer what is good. But the good thing is there is something for everybody. But we can do, if you start changing indication based only on Western papers, we may not be doing justice to our patient. We have to cater what is good for our patients. In fact, in India, 70% filarial and not post-cancer. So if you start doing for filarial people LVA, it will be a failure.
Oh, excellent. Thank you, Dr. Rajan, for taking that question. Any other questions anybody is having? I don't see any more questions here, but in case people are waiting, since we are in this pandemic thing, COVID pandemic, just a word upon, is it sort of affecting your practice and how is the situation in Chennai? Give us a little overview. Since we are here in Musk, since we are all locked down in our own places, we don't know what really is happening, and people are, sharing lots of things on WhatsApp, and not the ideal way to share things. But maybe give us a little overview.
As of now, people would agree that the general thing is lot of importance given in about the ventilators than the problem itself. And now people are understanding better about the pathophysiology. And already I'm hearing reports that the intubation should be the last option and not the first option. Why? What we see is people coming in and falling with a sudden fall of hypoxia. That means they come, they're all normal, suddenly they go into hypoxia and fall down. And all of them were actually intubated earlier. What my anesthetist colleague says, they don't want to intubate now early. And they're also saying people are able to have a low SpO2 of less than 85 and still be discharged without intubation. And they say probably intubation might kill the patient, but that is not my expertise. As for regarding my practice, it is across the board, practice has come down. My bread and butter of cancer surgery has come because they don't want any immunocompromised patient to get succumb to COVID, number one. There is no traffic, therefore there is no trauma. But what is still there is bed sores. All surgeries, orthopedic surgeries have been stopped. Now all of them are on traction. and even now I have to go and do a debrid bed sore. Bed sores are, I think, going to come more and more. But ultimately, I think from what I see in my ICU, if you're immunocompromised, you should not get COVID. So I think you should eat well, exercise well, be healthy. But what I see more common, people are trying to put the responsibility on institutions and telling only if you give a mask I will work, or I will not work, I will work even if there is no protection. It is the individual's responsibility to take care of protection with the equipments like mask, and I think doctors are taking it very lightly in terms of the risk of getting. Already my friends in UK are having COVID positive. So that is because of telling a surgeon can do anything, I am brave and all. I don't think it's like that. Hand and face hygiene is very important. When you come home, make sure you wash all your clothes in soap water. And the problem is not about you getting COVID, it is about your loved ones getting COVID in your home, and that you can never have any control. So take care.
Okay, thank you, Rajan. That was a very informative talk on plastic surgery. I think you can see by the number of questions that I think people are very appreciative of your talk. And thanks once again for joining us. And of course, we'll in the continuing webinar series, we'll have still talks from various parts. We have some from various parts of the world where COVID is active. So we'll have a lot of discussion on COVID-19, hopefully in the coming webinar series.
Sure.
Thank you, Rajan, once again for joining
Thanks
us. Thank you.
Bless.
Okay, we sign off from here.
Yeah.
And our next talk will be on Saturday. And please join us on Saturday for the webinar. We have Dr. Rachana, who is joining us from Glasgow for the talk. Thank you.
Thank you.
Okay.
Thanks a lot.
Bye-bye.